Hello, I'm Dr. Rachel Bushing. I'm the Director of Pop Psychology, Ride the Rainbow in 2023, and also our perinatal specialist service, Three Little Birds Perinatal Psychology. This short video is intended for mental health professionals who are experienced in working with people with all sorts of psychopathology, but might be new to the area of perinatal mental health. It's intended to give you some information about why we consider this to be a specialised area of practice, also trying to do a little bit of myth busting. So we're looking at trajectories towards postnatal depression and what sorts of things actually do come up in clinical practice, because newsflash, it goes beyond postnatal depression. So first of all, in defining the perinatal period, definitions can differ, but we consider that anything from preconception, and so that is kind of like thinking, planning, intending on launching your family and setting off down that pathway, through to conception, pregnancy. Often there can be pregnancy loss or infertility struggles along that journey, through birth and birth adversity into the postnatal. So some people will say that perinatal psychology goes up to about 12 months of age, which is infancy. We consider it to be up to, say, ages 3 to 4. So that's where we kind of train our staff, and that's where we see our remit. So obviously quite different presentations can come up across that perinatal journey. And that's why overarchingly perinatal psychology is a trans-theoretical approach to practice. The evidence base is pretty thin on the ground, actually, when it comes to answering the question, what is the gold standard best practice clinical intervention for parents who are presenting with psychological distress during the perinatal period. Postnatal depression was first identified in the mid-1800s. It was called puerperal depression, puerperal depression. But with the sort of evolution of psychiatry across the 20th century, around sort of like the 50s and 60s is when it first started to gain the attention of psychiatrists and was put into the DSM. And at the time, it was considered to be a really different type of depression, and assumed to be very associated with fluctuating levels of hormones, that for some women, as they experience the change of hormonal profile post-birth, things like the baby blues, which tends to be a bit of a hormonal slump. Many of our hormones go down in around day 3, day 4 after we have the baby. That can result in some dysphoric moods and some irritability. So the assumption was that some women just don't really recover from that baby blues slump and go on to continue to manifest depression across the months to come. But there hasn't really been much specific research into what is actually the dynamics and the pathways towards that postnatal depression. Women were kind of left to their own devices, much as they are today, but left to their own devices. Here's a baby on your way now, we should be happy. Oopsie, some women end up really, really depressed later on down the track. So as more research is coming on board into this field, we're able to see that actually probably postnatal depression is the least interesting presentation. And especially for me, early intervention tells us that we're needing to look a little bit more upstream, that these women with postnatal depression will have often experienced adversities in this perinatal phase of life. So unresolved losses, traumas, birth trauma being a really big one of those, and like a cascading of stressors and risk factors that overwhelms their resilience to cope. Because this should be a phase of life in which the mother is developing into a new type of being. It's a new phase of life. And so we're very sensitive to anything that's going wrong, that's rocking our confidence, that it can be distressing within this phase. Even more so because you're kind of given this baby and you know that you're meant to care and protect for the baby, and a lot of orientation goes towards how is it that we kind of keep the baby alive. You know, human infants take a lot of work. So there can be the tendency to set one's own needs aside during this process. We particularly know that hormones are, again, not the be-all and end-all. And for example, there's a lot more research coming on board identifying that fathers, non-birthing partners, are also at a high risk of developing depression, anxiety type concerns in this period of life. Statistically, we know it's about 1 in 5 mums that will manifest clinical anxiety and depression. At the moment, as far as we can tell, it's about 1 in 10 dads. But I think there's a recognition that that's probably an underreported number. And our mission is to try and make sure that we're considering the needs of both parents in this transitional phase for their family, for their identity in this phase of life. The other important thing that is really that we need to champion when it comes to perinatal psychology is that the burgeoning infant has their own resilience and risk factors. So anything that's going awry for this infant in the first weeks, months, years of their life, it's known as a really sensitive developmental period. So for us, we're really wanting to make sure that we're intervening with families at that time juncture in which issues are starting to manifest, right? So attachment disruption in the early years is correlated with some risk factors for further development of anxiety, depression for a child and into adulthood even. So part of what we're doing is really trying to do early intervention in a young person's life. And often that's via how it is that we're setting up the relationship dynamics, the environmental factors, and helping parents with their own intrusive mental health stuff, because all parents want to do the best that they can and they want the best for their baby. So for that reason, perinatal psychology, in terms of presentations and interventions that we use, it can be relatively wide-ranging. There's some evidence that acceptance and commitment therapy, compassion-focused therapies, these third-wave therapies have probably got a bit more utility than something like CBT. And it's because we're looking at multiple adjustments that the people are needing to navigate at this phase of life. So the intentions of how it is that we increase our resilience to withstand the difficult things in our life, using things like our value set to, look after ourselves, be kind to ourselves, bring in support, build a village, and be supported to kind of overcome barriers and be the kind of parent that we want to be. But our treatment can be really, really eclectic. Sometimes we're dealing with trauma, sometimes we're dealing with losses, sometimes we're dealing with family dynamics, sometimes we use a strengths-focused approach. It can be really quite wide-ranging, and I'm excited about the fact that the research is still kind of catching up with clinical practice, really. So what we really want to do is work on core principles. How is it that we support this dyad, the parent and the baby, looking out for both of their mental health and well-being as part of that dynamic? If we're looking after both mum and bub, then we're probably doing a lot right. Again, let's not forget about the non-birthing parent, because they're also very important for how it is that this environment is structuring the very best start of life. That's it. And if you'd like to learn more, because we are recruiting and adding to our team, we've now got a team of 11 perinatal psychologists across 2 locations in Brisbane. As we get staff, we are training them as to how to become a perinatal specialist. So we offer training as part of our staff induction program, and we've also opened up that training for outside applicants. So our Full Circle program is an 8-week online small group program, which is based around the very basics of an introduction to perinatal psychology. So please do look us up if you're interested. Otherwise, we can come tell you more, and hope to see you soon. Thanks so much. Bye.